Welcome once again in the second session of this live interactive teleconference of the postgraduate diploma in clinical cardiology. Today we are discussing congenital heart disease. We have already received few communication from the students that the result of the Hyderabad student, it is already in the process. Within few days you will get the books for this Calcutta center. I think it must be on the way because few centers already received. Third is a few students, they ask to start with the basic pathophysiology as well as hemodynamics. Regarding that, I would like to mention that this is actually very vast topic. So basically here we are just giving you overview, just introduction type of things. It is not an exclusive issues. Otherwise, for each sessions like atrial septal defect, we need an entire 3 sessions big for the BSD, like for the echo separately, like that entire things is required, and gradually we try to come up according to your recommendations and your requirement. That is the reason I would like to request all of you, please suggest us and tell us what are the things you want to learn and how much you want to learn, so we can also inform our expert that these are the requirement of our student. So please address all this issue. But in these sessions we are definitely going to do the overview, just like introduction type of things, and we are not going too much on management. And basically in the sessions we are going to discuss the obstructive heart disease, and as previous sessions Dr. Manish Tomar told, that is prevalence incidence of these congenital heart disease is 1% in 100 live births, and in this case it is among the heart diseases, it is 5 to 10% are counted as obstructive heart diseases. In these sessions we are mainly going to discuss about the aortic stenosis and pulmonary stenosis. We are not going to discuss too much on this mitral stenosis and tricuspid stenosis because these are the rare phenomenon. Basically the discussion of this focus of this discussion will be remaining on this outflow tract obstructive diseases. So I would like to request our experts, Dr. Manish Tomar, to continue with this obstructive heart diseases.
After the shunt lesion in acyanotic heart disease, we come to the obstructive heart lesions, obstructive outflow tract lesions. The left-sided obstructive lesions and the right-sided obstructive lesions. Left-sided obstructive lesions are dominantly aortic stenosis at the level of valve, supravalvular or subvalvular aortic stenosis, and the coarctation of aorta. And on the right-sided, it is valvular pulmonary stenosis, infundibular pulmonary stenosis, and the peripheral pulmonary stenosis.
Here because it is not, I would like to add that it is not like this, that there is no congenital mitral stenosis. There is an entity known as congenital mitral stenosis due to mitral valve deformity, but since it's a very rare deformity, so we are not right now concentrating on that. And similarly, the tricuspid stenosis is a very rare entity, and an isolated tricuspid stenosis is a very rare entity. Usually what happens is that in complex congenital heart disease, where there is associated right ventricular hypoplasia, we can get a hypoplastic tricuspid valve or a tricuspid stenosis. So here we are not going to discuss this thing. And also regurgitant lesions like mitral stenosis, mitral regurgitation, tricuspid regurgitation, aortic regurgitation, and pulmonary regurgitation we are not going to discuss here, because mitral regurgitation would be discussed as a part of a adult rheumatic heart disease. And similarly aortic regurgitation is also, though can be congenital also, but is the pathophysiology would be similar to as that in a rheumatic etiology. So here we would be concentrating only on outflow tract obstruction, that is left ventricular outflow tract, can be valvular, subvalvular, supravalvular, pulmonary, and other is the right ventricular outflow tract, which is pulmonary stenosis, which can be valvular or subvalvular. I think so I should hand over to Dr. Manish.
Come to the left-sided obstructive lesions. The presentation usually in left-sided obstructive lesion is the incidental detection of murmur. With increasing severity of stenosis, we get dyspnea on exertion, early fatigability. With very severe stenosis, even syncope, angina, and with coarctation, usually the claudication, leg pains is the usual presentation because of reduced flow in lower limbs, and the detection of hypertension on routine evaluation. Examination shows as there is stenosis of the outflow tract, we get narrow pulse pressure with coarctation, radiofemoral delay or even absent femorals. Forceful and heaving cardiac apex. LV, there is left ventricular hypertrophy. Left ventricular hypertrophy is because of the increase after load for that ventricle. So the left ventricular hypertrophy on examination we find forceful and heaving apex. Systolic thrill in the aortic stenosis on the right second intercostal space in the carotids. The systolic thrill usually does not correlate with the severity of stenosis. Even with the mild stenosis we get systolic thrill relating to the carotids. First heart sound usually normal. Second heart sound narrow, single or the paradoxical split. Here again, second heart sound A2 component with the aortic stenosis. With aortic stenosis there is delayed opening of the aortic valve. So A2 will be delayed. A2 will be delayed with as the severity increases, the A2-P2 interval decreases, and even with severe stenosis we get the reverse split. Constant ejection click. Constant ejection click, if it is there, it is the feature of the bicuspid aortic valve which is pliable and which is the cause of the aortic stenosis. With subvalvular aortic stenosis or supravalvular aortic stenosis we do not get the ejection click. If there is associated bicuspid aortic valve we may get, but isolated subvalvular or supravalvular we do not get the ejection click. LV S4. Left ventricle S4, fourth heart sound we get with the, as the left ventricular hypertrophies with the A wave means atrial contraction we get the S4. And if there is development of the heart failure we get the LV S3.
Here I like to add that due to Gallivardian phenomena, which is because of the filtration of a selective high frequency sound, the findings of aortic stenosis would be better heard at apex rather than at the aortic and neo-aortic area. By aortic area I mean the right second intercostal space and in the parasternal area, and by neo-aortic area I mean the left second intercostal space which is just below the pulmonary area. So this is a characteristic thing in patients with with a valvular left-sided obstructive lesion, that the findings would be better heard at apex, because to differentiate a right ventricular outflow tract lesion from a left ventricular outflow tract lesion is very difficult on the basis of murmur alone, because you are going to hear a similar kind of murmur in a pulmonary stenosis as well in aortic stenosis. The difference would be in terms of the location of the murmur. That is, the aortic stenosis murmur would be better heard in the right side also, and there would be clear-cut radiation to the carotids, while in case of pulmonary stenosis the murmur would be better heard on the left side, and the murmur and the ejection click would be localized, while in case of aortic stenosis the murmur as well as the ejection click of the aortic valve would be better heard in the apex also. So as you know, the various areas of the auscultation in cardiac auscultation, the findings of the left-sided ventricular outflow tract obstruction would be better heard, sometimes better heard at apex. So this is a point to differentiate clinically on bedside the left-sided and right-sided outflow tract lesions.
So murmur, as Dr. Prashant has discussed, the location of murmur is very important. Though it is not a very specific thing, you cannot clearly differentiate between left or right, but you have to see the associated thing where the murmur is radiating. With any obstructive lesion you get the ejection systolic murmur. depending on the severity, the grading of the murmur, and depending on the location of the stenosis. With the subvalvular stenosis, the murmur is on the left side. With the valvular aortic stenosis, this is on the right side and radiation towards the carotid. With coarctation of aorta, we get a continuous murmur or the systolic murmur, which is heard in the interscapular area posteriorly in the back. Early diastolic murmur is not a feature of the obstructive lesions. If it is there, we have to look for the aortic regurgitation, and aortic regurgitation is common with the subvalvular aortic stenosis. The subvalvular aortic stenosis is just below the valve. The jet of the aortic flow with the subaortic stenosis cause some damage at the aortic valve, leading to the development of aortic regurgitation. So aortic regurgitation is commonly, not in 100%, but commonly associated with the subvalvular aortic stenosis. Now come the severity of aortic stenosis. By the few clinical things, we can make out the child is having severe aortic stenosis or the mild aortic stenosis. The moderate may have the symptomatic or maybe asymptomatic, but patient, if he is symptomatic, if there is no other cause for the cardiac symptoms, we have to look for the severe aortic stenosis, presence of narrow pulse pressure, late peaking of ejection systolic murmur. With increased severity, increased afterload, the murmur will be late peaking, ending up to the second heart sound, corresponding second heart sound. So late peaking of the ejection systolic murmur, the delay in the A2 component of the second heart sound. As the aortic stenosis increases, there will be delay in the A2, so the second heart sound will be single or the paradoxical split. Now come the ejection click. Ejection click comes closer to second S1 as the stenosis increases. So with increasing severity of stenosis, we get narrow or superimposed S1 and the ejection clip gap. Presence of S4, and definitely if there is LV failure, patient is definitely having critical or the severe aortic stenosis.
Here the last point I want to reiterate and say that the S3 comes later in feature of aortic stenosis. S3 occurs before S4 in the diastole, but presence of S4 suggests severe aortic stenosis, but presence of S3 suggests left ventricular failure due to severe aortic stenosis. So presence of S3 is more ominous than presence of S4. And if we see the history, natural course, the S4 will come before, as the severity of the left ventricular outflow tract obstruction increases, and S3 is a later finding. So if you find S3 also, that means that patient has gone into left ventricular dysfunction due to severe aortic stenosis, which is an advanced stage which requires urgent intervention.
After the clinical, it is the electrocardiography. If we see the left sided obstructive lesion and the right sided obstructive lesion, ECG is usually not very specific, but sensitivity is there, and with increasing severity of stenosis, we get the definite changes in the ECG. Usually access is normal with left sided obstructive lesions. ST-T wave changes, if there is severe aortic stenosis, appearance of ST-T wave changes will be there. These are, with mild aortic stenosis, we get usually normal ECG. With moderate, no definite change. There may be left ventricular hypertrophy, but with severe stenosis, there will be LVH with ST-T wave changes. And on chest X-ray, there is no cardiomegaly usually. If there is no heart failure, no cardiomegaly. If there is cardiac failure in aortic stenosis, then we get cardiomegaly. Dilated ascending aorta because of bicuspid aortic valve, but with supravalvular aortic stenosis, we do not get dilated ascending aorta, and rib notching will usually appear after 4 or 5 years of age in coarctation of aorta because of presence of collateral. The rib notching in coarctation of aorta appear from third onward ribs. The simple reason is because first and second intercostal arteries do not arise from the distal descending aorta, distal to coarctation. It is arising from the costo-cervical trunk, which is proximal to the coarctation. So rib notching is a feature of coarctation, usually appear in later childhood after 3-4 years of age, and it involve only ribs from 3rd to 12th. The ECG, this is the ECG showing in this was a 2-year-old child with critical valvular aortic stenosis. The ECG showing severe left ventricular hypertrophy. This is on the half. The chest leads are on the half voltage. This is on the 5 you can see, and 15 means 30 you can double it with addition of the S wave in V1 and the R wave in V6. There is severe left ventricular hypertrophy with the left axis division.
Here I would like to add, just to revise what Madam has told about the left ventricular outflow tract lesion, that the ECG is not a very sensitive modality for assessment of severity of left ventricular outflow tract obstruction. And when I was discussing earlier the location of the murmur, I was discussing about the valvular aortic stenosis. Now if the stenosis is subvalvular, in a subaortic stenosis, the location of the murmur would be on the left side, because if you can recollect the anatomical location of the aorta and the left ventricular outflow tract, the aorta rises on the left side, from the left side of the heart, and the subaortic obstruction would be on the left side of the sternum, while as the aorta goes through the arch, the supravalvular stenosis would be better heard on the right side with a good radiation to the carotid. Obviously carotids are a continuation of the great vessel, that is aorta, so any murmur, whether valvular or supravalvular, would be preferentially conducted to the carotids. So you are going to hear them very loudly on the carotids. But subvalvular aortic stenosis, the murmur would not be as well heard in the carotids. It would be better heard in the left parasternal area, slightly lower to the neo-aortic area. And as Madam has already suggested, that the presence of AR, presence of early diastolic murmur of aortic regurgitation, and presence of murmur of the ejection systolic murmur on the left parasternal space would favor a subaortic obstruction, because the chances of aortic regurgitation is more in subaortic obstruction, and the location of murmur would be on the left side. Though aortic regurgitation can occur with a bicuspid aortic valve also, but here the location of murmur, the systolic murmur, the ejection systolic murmur would be what I have already told you on the right side. So based on the location of the murmur, we can get a broad idea whether this obstruction is valvular, subvalvular or supravalvular. Apart from this, a supravalvular aortic stenosis will have a very classical finding, which is known as Coanda effect. Now in Coanda effect, what happens is, because of the jet of the supravalvular aortic stenosis getting preferentially towards the right great vessels, right upper limb vessels, hitting directly on the right brachiocephalic trunk, the pulse of the right upper limb would be bounding, and the blood pressure of the right upper limb would be slightly more than the left. So this is known as Coanda effect. So apart from whatever precordial finding you are getting, if you are getting a pulse volume which is unequal on the both sides with a louder on the right side, why I am telling you is that because sometime in coarctation, if you have involvement of left subclavian artery arises near the juxtaductal area, which is the commonest site of the coarctation, you can have left subclavian involvement, the left subclavian orifice is obstructed. So you can have a left upper limb pulse which is feeble or absent. So here you will have two differentials. It can be, the feeble can be due to coarctation or it can be due to a supravalvular AS. But here again the location of murmur, the conduction of murmur to the back, which is a characteristic feature of coarctation of aorta, will help you in differentiating, because getting an unequal upper limb pulse can be there in both the cases. However, in supravalvular aortic stenosis the difference is mild. You will never get an absent pulse on the left side, which can be the case in coarctation of aorta, where the orifice of left subclavian artery is getting involved, and sometimes it is so severely narrow that the left side pulse cannot be felt at all. So this is something which I like to add, and I think so madam should continue with the other things.
Yeah, one thing is in quanta effect there will be pulse pressure difference, but pulse will be palpable on both sides. With coarct, if there is severe coarctation with involvement of the left subclavian artery, the pulse will be feeble. Definitely it will not be feeble. Supravalvular AS will not be feeble, but with coarctation of aorta it will be feeble. Plus just one thing more to add, sometime with coarctation of aorta we can get aberrant origin of the right subclavian artery. We can get involvement of both subclavian arteries, because there is aberrant origin of right one and left one is arising at the site of coarctation. So with the coarctation of aorta we can get absent pulses in both upper limbs, and lower limbs will be feeble. Obviously it is coarctation of aorta. Only the carotid can make the difference. So carotid should be felt in all patients with when you are doing cardiac examination. You should feel all peripheral pulses, means all upper limb, lower limb and the carotids also, before making one diagnosis. Okay. Plus as we are just going to the difference in pulses, in with supravalvular AS sometimes we get involvement of the branches, aortic arch branches. In that case we can get difference in pulses, means this finding quanta effect will not work if the right sided subclavian is involved. Sometimes Takayasu arthritis, multiple involvement of the arch vessels, we can get this difference. Even carotid may be involved. So we have to look for all pulses before making a diagnosis. Means it is supravalvular AS or coarctation, involvement of multiple arch vessels, plus auscultation for the bruit, which is very important, means to see the involvement of the renal vessels. Just as we are going to the, we were discussing about the arch vessels involvement.
So I think so madam, what inference we have got is that when we are assessing a patient for a point of view from a coarctation, a radiofemoral delay, which is classically known as the sign, we should not only rely on that. We should definitely see a radiofemoral delay, but as madam has already told that if there is involvement of upper limb pulses, this radiofemoral delay would not be evident. In that case, a discrepancy between the carotids and the lower limb would be the only sign available. If there is aberrant origin of the right side and involvement of the left side. By aberrant origin of the right subclavian, we mean that the right subclavian, instead of arising from the proximal segment which of the coarctation, it is arising from the distal segment of the coarct segment. So definitely it will be also feeble. So both upper limb and the lower limb pulses would be feeble to the equal extent, and you are not going to get a radiofemoral delay. But classical teaching is that radiofemoral delay should be sought for, but yes, these are the exceptional cases where we should see for carotids also. And this is basically a point which stress that we should examine all peripheral pulses, which is always been told as a part of cardiovascular examination. Madam, please continue.
Just in very short, management of left-sided obstructive lesions. For the valvular aortic stenosis, if valve is pliable, there is no significant aortic regurgitation. severe aortic stenosis, we go by the definition, by the gradient, mean of more than 40 millimeter of mercury on echo. Balloon dilatation is the treatment of choice. For subvalvular aortic stenosis and the supravalvular aortic stenosis, it is surgery which is the only option. And for the coarctation of aorta at our institute, the policy which we follow is in early infancy, surgery is the only treatment which we offer to the patient. If patient is in like suppose having sepsis or in multi-organ failure, we can not take the patient for the surgery. That time we give just for palliation, balloon dilatation, balloon dilatation or the coarctation. But our primary first option is the surgery for the early infancy. After infancy, it's the balloon dilatation for the coarctation. And after 9 years of age or more than 27 kg, we look for the anatomy and we offer for the balloon dilatation and stenting of coarctation both. But if there is associated heart defect, patient has to go for the surgery, or arch is severely hypoplastic, or arch vessel origin is so that we cannot intervene by percutaneous, we send the child for the surgery.
So in short, a discrete coarctation in a bigger child, that is in post-infancy, is a candidate for percutaneous intervention. The discrete localized narrowing of the aorta is the most important factor. If there is any associated lesion, or if there is a transverse aortic arch hypoplasia or any other intracardiac lesion, then open heart surgery for that intracardiac lesion, or a closed heart surgery by which coarctation repair is the option available. So this is in brief about the management.
Now come the right-sided obstructive lesions. As with the left, right again has infundibular stenosis, valvular stenosis and the supravalvular pulmonary stenosis. The commonest presentation is the incidental detection of the murmur on routine evaluation. With increasing severity, we get fatigue, cyanosis with the severe or critical aortic stenosis leading to left or right shunt at the level of atria. Rarely we can get angina after exercise, and if there is with critical stenosis right ventricular failure, we can get feature of that in form of hepatomegaly and the raised jugular venous pressure. With severe stenosis with right ventricular hypertrophy, there will be right ventricular heave. There can be thrill. First heart sound usually normal. Second heart sound, as there is severe pulmonary stenosis, increased right ventricular afterload, so P2 will be delayed. If there is no right ventricular failure, no intracardiac shunt, intensity of P2 usually maintained. So we get wide variable split with delayed P2. If there is RV failure, we get soft or inaudible pulmonary component of second heart sound. Inconstant ejection click. If there is valvular level of stenosis, and narrow or superimposed ejection click S1 gap. This goes with the increasing in severity of pulmonary stenosis as with the aortic stenosis. S4 sound on right ventricular side and S3 if there is right ventricular failure. All findings of the right and left sided obstructive lesions go in same way because hemodynamics and pathophysiology are same. In addition to these findings, with peripheral pulmonary stenosis, we get S2 wide, but P2 will be loud. As our resistance is beyond the pulmonary valve, main pulmonary artery pressures will be high. With peripheral pulmonary artery stenosis, we get loud P2. With sometimes get early diastolic murmur, which is of pulmonary regurgitation. Then the ejection systolic murmur or the continuous murmur, depending on the pulmonary artery involvement, site of murmur and radiation to the same lung. The ECG is more sensitive and specific than the left-sided obstructive lesion on the right sides. With mild pulmonary stenosis, the ECG is usually normal. With moderate pulmonary stenosis, in around 10% of cases we get the normal ECG. Otherwise, there are changes in form of right axis deviation, R or only RS, with RS ratio more than 4 in V1, and tall R wave. Usually it's in range of the 12 to 20 millimeter, but with moderate PS it's not usually more than 20 millimeter in amplitude. With severe pulmonary stenosis, there will be further right axis deviation, pure R or QR in V1, with even T wave inversion, R wave more than 20 millimeter, with right atrial overload and deeply inverted T waves. And there will be delayed transition. Delayed transition means, you can see on this ECG, this is the 4-year-old child with critical valvular pulmonary stenosis. This is V1 to V6. You can see there is no change in the QRS pattern. Just right-sided forces are persisting up to the V6. To see the left-sided forces, we have to take V7, V8. Means we have to go further left side. But by this ECG, there is no transition from the right-sided forces to the left-sided forces. With there is obvious right axis deviation, with RA enlargement, T wave inversion. Means this ECG is showing all classical features of the pulmonary stenosis, critical pulmonary stenosis with intact ventricular septum.
Here, because the RV is dilated also, and it is occupying most of the precordial region, where the normally placed chest leads are there. That is why we are getting a monomorphic or a similar kind of ECG. Why we are not getting a left ventricular forces in this chest lead is because that at the usual site of V5, V6 there is RV, because of the RV dilatation and hypertrophy. So the right ventricle is occupying the most of the anterior chest wall, and the left ventricle is being pushed into side the back of the precordium. So for getting a for picking left ventricular voltages, we have to put a lead which is in the axilla or at the back, which is V6, V7, V8. So this is the mechanism behind this thing.
Just in short about the management of right-sided obstructive lesions. For the valvular pulmonary stenosis with moderate to severe pulmonary stenosis, balloon dilatation is very good option and with very good results. Even long-term results are very good. In newborn, if we do balloon dilatation of the valvular pulmonary stenosis, there are some chances of restenosis around 5 to 10%, but after that the restenosis is very less common with the valvular pulmonary stenosis balloon dilatation. But for infundibular pulmonary stenosis, it is the muscle bundle as a surgery is the only option, and for the peripheral pulmonary stenosis requiring intervention, result of surgery are not very good. Chances of restenosis are there. We have to see according to the age of the child, and if child is grown up, the option is the stenting. Even result of balloon dilatation are not good for the peripheral pulmonary artery stenosis. Here I would like to just address some questions.
Yeah, we have some of our students at Ranchi, and they have asked a question related to our previous session. So first question was, ma'am, regarding the correlation of blood pressure with hemodynamics of VSD and its size. They want to get clarification on how the VSD gradient and the blood pressure are related to each other, and how we are going to assess. I think so you would be the best person.
When there is ventricular septal defect, means there is communication between the two, left ventricle and the right ventricle. If there is no aortic stenosis, LV pressures are equal to the aortic pressure, aortic systolic pressure. So indirectly by taking the blood pressure, we are getting the LV systolic pressure, and by differentiating the pressure gradient from the which we are getting on the echo, we can take the right-sided pressure and RV pressure, and if there is no pulmonary stenosis, we can get indirectly the pulmonary artery systolic pressure. So BP is very important for any hemodynamic assessment. Suppose, can I draw?
No, ma'am, actually.
It's not.
No,
Suppose Suppose on echo we get LV-RV pressure difference of 40 millimeter of mercury, and the child blood pressure is, systolic blood pressure is 100 millimeter of mercury. So 100 minus 40 is the 60, means RV pressures are 60. RV pressure 60 means PA systolic pressure is 60. So 60 blood pressure, 60 PA pressures means pulmonary pressures are definitely elevated. If child pressure BP is 140 millimeter of mercury and this 40 gradient, PA pressure will be 100 millimeter of mercury. So simultaneous means it is not that we are doing echo now and taking the blood pressure after 1 hour or in the evening. That is not. We have to take blood pressure during the echocardiography only to assess proper assessment of the pulmonary artery pressure.
Here I would like to add that regarding the hemodynamic definition of VSD, ma'am, I think so if we can tell them about the what is the definition of hemodynamic definition of a VSD, that RV pressure less than 1/3 and half and then more than 2/3 for that thing.
That is for the
because blood pressure is in children will vary, so the pressure gradient is blood pressure is as important as the pressure gradient, because with age the blood pressure is going to be changing. In small babies the systolic blood pressure is low, in adults it is different. So we just want to have a
one thing is the comparison of the right-sided pressures with the systemic pressure. Systemic pressure means we have the blood pressure with us. For the here just we left one thing in between with the right-sided obstructive lesions. Right-sided obstructive lesions we go more by the right ventricular pressure, which we take by the TR gradient. These are all our echo things in addition to the blood pressure we take. If right-sided pressures are less than 50% of systemic pressure, that is we compare with the we have blood pressure and we have the TR gradient. So right-sided pressure less than 50% systemic means our RV pressures are mildly elevated. If it is between 50 to 100 of the systolic pressure, these are moderately elevated. If the right-sided means RV pressures are more than 100% of the systemic pressure means systolic blood pressure means it is severely elevated. This is with the right-sided means pulmonary stenosis with intact ventricular septum. Pulmonary with ventricular septal defect, again almost definitions are same. Here we go by the pressure gradient. We have the VSD, we have the by echo, we have the difference between the left side LV and the right RV. LV pressure again it is a systolic pressure, excluding there is no aortic stenosis or coarctation of aorta. Then non-restrictive VSD means our RV pressure, LV pressure same, means RV pressure are of the same of the systolic blood pressure, means there is significant pulmonary arterial hypertension. Difference less than 25 millimeter of mercury. Moderately restrictive pressure means gradient between LV RV is 25 to 60 millimeter of mercury, and non-restrictive ventricular septal defect means there is significant difference between the left ventricle and the right ventricle, that is more than 60 millimeter of mercury. But these definitions, these absolute value cannot be taken in isolation. We have to take the blood pressure. Obviously 60 difference with 160 blood pressure or 100 blood pressure take different pulmonary arterial pressure. So simultaneous while doing the echo, recording of blood pressure is very important to calculate the pulmonary arterial pressure non-invisively while you are doing the echocardiography.
I think so it was a little tricky thing, and we have tried our level best to explain this query.
But sir, if the question can be asked in a different way, suppose the size of the BSD is small, and in another case size of the BSD is larger. So what is the probability of getting hypertension or blood pressure differences if we count as the other component of the heart is entirely normal? Then
No.
is it like smaller VSD will have a lesser development of blood pressure, or
No.
larger VSD has got?
No, blood pressure has nothing to do with the VSD. When we are measuring blood pressure, we are measuring the left ventricular pressure, because the systemic systolic blood pressure would be equal to the left ventricular systolic blood pressure,
Yeah.
provided there is no obstruction in the outflow. So the blood pressure, absolute value of blood pressure is important, because what we are measuring on echo is a gradient, that is a difference of pressure across the VSD. So to get an absolute value of the right ventricular blood pressure, we should have a value of the left ventricular systolic pressure. If we subtract the difference from the left ventricular blood pressure, the pressure in the LV minus the gradient which we get across on echo would give us the right ventricular systolic pressure. So by measuring or by knowing the right ventricular systolic pressure, we can say whether the right ventricular and the pulmonary artery are facing high pressure or not. Now if the right ventricle and pulmonary artery are having a low pressure, that means the pulmonary vasculature is not subjected to high pressure. So that is a very important thing when we are labeling a VSD as small, moderate or large, because in a large it would be a pulmonary arterial hypertension, pulmonary vascular bed would be facing a very high blood pressure, very high pressure.
Here one thing is very important. When like we are doing echo, we know VSD is small and we are getting significant gradient in a small child. And just this is the indirect correlation. You are getting gradient of 90 in a 5-6 month old child across the VSD. You have to look for the blood pressure, means there has to be definitely systemic arterial hypertension. So child may be coming to you for the systemic arterial hypertension, not because of the VSD, because a small VSD, you know, echo wise it is a small, restrictive, there is no other explanation. Significant means unexpected high gradient across a VSD, means you have to see the difference. 90, 100, 120 gradient across the VSD means you should take the blood pressure. There might be systolic arterial hypertension which you are missing. So both things are important. VSD is important, gradient is important, but aortic pressure is good. You have to correlate both things.
And there was another query which was about the medical management of congestive heart failure following ASD and VSD. I think so this is a separate topic if we can deal with the congestive heart failure in a separate way. Though the management of congestive heart failure in a patient with VSD and CHF would be very much similar to a management of CHF in any child. And other query was what is bidirectional shunt and what is Eisenmenger syndrome. I think so.
I think
this will require
this topic we'll discuss in the next session.
Because it's a big topic and I think so it will require a substantial time to be discussed.
Yeah, actually this is the one reason I always appreciate the center from the Ranchi student, and they always interact through phone or by the fax, as well as we have got retained feedback from the St. John Hospital like centers and from sometime Hyderabad also. And in these sessions we will stop here. Basically in these sessions we have discussed about the the obstructive heart diseases, mainly on the aortic stenosis and pulmonary stenosis, starting from the etiology, presentation, as well as their diagnostic like ECG, and the management component also. Medical management we are mainly giving priority, and these are two other things we didn't discuss, like mitral stenosis and tricuspid stenosis. In our next sessions we will discuss about these questions, whatever is left, as well as cyanotic heart diseases. So friends, today right now we are concluded here, and we will meet after 15 minutes later. Thank you very much.
Thank you.